Good afternoon, everyone. So we'll be presenting a rare case of scleritis, which actually exemplifies a case of a diagnostic dilemma, wherein the disease entity failed to fit into one single etiology, as scleritis is usually infectious or autoimmune or associated with neoplasms, and our case did not really fall into any one single entity, rather had overlapping features of two etiologies of hyperproliferative as well as autoimmune etiologies. So, Dr. So this case it required a very multidisciplinary kind of approach for us because we required the imaging and the pathology. We have with us Professor Sanjay Sharma sir and Dr. Shojat from the Department of Radiology RP Center, and from the Department of ENT we have Dr. Suchita Singh and Dr. Ashish and Dr. Kavneet Kaur and Dr. Ashwita from the Department of Pathology. We also have with us Professor Rachna Meen, who is in our oculoplasty department, and Professor Seema Sen from the ocular pathology department in RP Center will be giving their inputs in the case. And we'll be covering the case in these heads. I would like to invite Dr. Aisha to start the case presentation.
A very good afternoon to one and all. A 40-year-old gentleman who is a caterer by occupation presented to our center with history of diminution in vision in the left eye since the last 7 months, which was gradually progressive in nature. History of recurrent episodes of pain, redness, and watering in the left eye, which was on and off for the last 5 years. History of presenting illness. He gives a history of developing redness and pain in the left eye, which was associated with headache around 2020, for which he visited a local hospital in Indore. But patient was lost to follow-up till 2025, and he gives a history of intake of oral steroids occasionally on developing any symptoms. But on April 2025, he noticed a severe diminution of vision in the left eye, and he visited a local hospital in Indore, and the best corrected visual acuity noted was 2 by 60 with vitritis and temporal scleral thinning, and an NDR capsulotomy was done. In the next visit, this edema was also noted. Further, she was advised for undergoing an MRI orbit scan and USG scan. So, past history, if we look, he gives a history in the contralateral eye in 2014, history of pain, redness, and watering in the right eye, which was also similarly waxing and waning in nature. In 2018, he gives history of loss of vision associated with repetition of extraocular movements, proptosis, and drooping of eyelid, which was associated with headache. On 7th May 2018, he visited a private hospital in Indore and he underwent a right nasal endoscopic biopsy from the frontal ethmoid and maxillary sinus. Histopathological examination of this showed mucosa lined by columnar cells with stroma showing infiltrates of lymphocytes, polymorphs, plasma cells, and eosinophils, but there was no fungal evidence. Further, on 13th May 2018, he underwent a right eye acceleration as an orbital mass was suspected. Best corrected visual acuity in the left eye noted during this period was 6 by 9. Histopathology report of the accentrated tissue showed a grossly large grayish-white mass occupying the posterior half of the eyeball, including the sclera and invading surrounding soft tissue. There was no infiltration of tumor in the posterior chamber, but the optic nerve was noted to be embedded in it. And microscopically, there was myofibroblastic and fibroblastic spindle cells accompanied by dense collagen and patchy collections of polymorphs, lymphocytes, and histiocytes. IC panel done showed CD68 positive histiocytes, but ALK1 was negative, and fungal stains were negative. And an impression of inflammatory myofibroblastic tumor was made. Systemic history of the patient is a known case of type 2 diabetes mellitus on treatment since 2017 on oral hypoglycemic agent, which was well controlled. No history of any ear discharge, hemoptysis, recurrent cough, fever, hematuria, decreased urine output, joint pain, rashes, etc. Going on to the clinical examination, patient presented to our center in August 2025, right eye was accentrated, and in left eye, the vision noted was bigger counting at 1 meter with projection of rays accurate, intraocular pressure was 11 mmHg, cornea was clear, anterior chamber showed AC cells of 2 plus, lens is pseudophakic, and scleral, as shown in the imaging, there was a severe temporal scleral thinning with 1 into 1 mm area of scleral lens was present. Diffuse congestion noted along the temporal side, and the surrounding area had prominent vessels. On examination, the growth was present. Vitritis was noted with a media haze of 3 plus. This was hazily visible, and this edema was present as seen in the image. Macular OCT image also showed a neurosensory detachment at the macula. No clinically palpable lymph nodes were present. This is the clinical image of the patient. As seen, we can easily observe the temporal congestion along with scleral thinning and melt. So going to the management, on admission we got the battery of investigations done. Our main aim initially was to rule out any local infective pathology for which a conjunctival swab was sent and the report came to be sterile. Further, we had to evaluate for any other systemic infections, especially tuberculosis and syphilis, for which Monto test was found to be negative, chest X-ray was within normal limits, and BDRL was negative. Next, our aim was to evaluate for any systemic autoimmune diseases. Blood investigation was done. There is routine blood investigation like CBC, LFT, KFT, inflammatory markers such as ESR, CRP, and specific investigations for vaginal anger was done, rheumatoid arthritis, RA factor, anti-CCP, IgG4 was done, as well as serum calcium and ACE. B scan eventually showed no T sign in order to rule out posterior scleritis. Further, this is a baseline blood investigation report. Everything was found to be normal. IgG4, other than IgG4 which was raised, which was 150 milligram per deciliter, CRP was raised, ASR was raised, as well as anti-CCP was raised. Based on the initial findings, an empirical treatment was started, enteral antibiotics, topical fortified antibiotic drops, concentrated cetirizine 5%, 1 hourly, and concentrated topramycin 1.3% 1 hourly. Topical cyclopages were given. Oral MPs, matrix metalloproteinase inhibitor, tab-doxy was given 100 mg BD, which helps to reduce the further sterile mass by decreasing the degradation and increasing the collagen synthesis. Similarly, collagen synthesis is promoted as tab vitamin C 500 mg 4 times per day was given along with topical lubricants and oral antibiotics. And imaging was also done. CMRI brain and orbit, CCT orbit, CCT chest and abdomen, and PET CT scan was also done for this patient. So we have from the Department of Radiology, Senior Resident Dr. Shujar, to discuss further about the imaging.
Good afternoon once again. I will be presenting the imaging part of the case. We have 2 point time scans. First one is at the initial presentation prior to the right exenteration. As we can see, at this time the complaints were in the right eye. First, we will look at the left eye, which is the normal side. We can appreciate this is the T1 accelerated image. We can see the bright retrobulbar fat clearly delineating the optic nerve, medial rectus, and lateral rectus. But when we compare to the contralateral side, the disease side, there is complete obliteration of the retroorbital fat, and there is no distinction of the medial rectus, optic nerve, and lateral rectus at the same places. There is the lesion is totally it is multi-compartmental, extending from the medial wall up to the lateral wall. So a multi-compartmental lesion seen involving the retrobulbar space, causing the compression and scalloping of the globe posteriorly. On the coronal image, we can see this is a circumferential mass T2. This is a T2 weighted image, T2 hypointense mass completely encircling the globe. As we can see on the normal side, the fat should look like this, but it is completely replaced by T2 hypointense soft tissue. This is the fat saturation image showing this mass lesion. It appears to be mildly T2 hyperintense, suggesting something edema within the mass or active disease within the mass. This is the sagittal image showing the T2 hypointense mass lesion in the retrobulbar space. We can also see in the surroundings that there is mucosal thickening in the right maxillary sinus, left maxillary sinus, and the right adjacent ethmoid sinuses. So this is the post-contrast imaging of this same time, showing that mass lesion is homogeneously enhancing on the coronal and the axial image, compressing the globe posteriorly and extending up to the orbital apex. So after this, the patient has now presented again with the complaints in the contralateral eye. At this time, CCT orbit CMRI orbit and CCT chest abdomen was planned. So as we can see, there are the post-operative changes in the form of right exenteration. We can see there is also on focusing on this eye right now, as we have complaints in the eye. There is an enhancing lesion involving the inferomedial aspect of the left orbit, which is completely encasing the inferior rectus muscle and is also abetting the medial rectus muscle and the optic nerve, and reaching up to the lateral rectus muscle. So this is the bone window image of the same to show is there any bony erosion. There is no bony erosion of the floor of the orbit. However, we can see that there is the sinus disease here in bilateral maxillary sinuses. There is also septal perforation, and there are also some post-operative changes in the right eye. So coming to the CEMRI, which was done after this, again showing the post-operative changes in the form of right exenteration. We can see on this T1-weighted image, this fat is replaced by this T2 hypointense tissue, similar to that which we saw earlier in the right eye. The mass is T2 hypointense encasing the inferior rectus and reaching up to the optic nerve here. The region is not that much enhancing on the CMR images. So to summarize the case, we have a multi-compartmental lesion, ill-defined infiltrative lesion, T1 intermediate, T2 hypointense involving the left orbit. Similar appearance was seen in the prior pre-operative imaging on the right side. There is the lesion is multi-compartmental and it is presently encasing the inferior rectus muscle. There are no bone erosions and there is sinus disease with nasal septal perforation. Based on this profile, first it involved the one orbit, then the second orbit, though we kept the possibility of the systemic inflammatory disease affecting bilateral orbits. Possibilities which we like to consider are IgG4 related ophthalmic disease, granulomatosis with polyangiitis in view of the sinus disease and plus sinus perforation, and non-Langerhans cell histiocytosis can also present like this, and idiopathic orbital inflammatory disease or sclerosing IOD, and because these masses are T2 hypointense and they do not enhance as much as we have seen in the second presentation. So sclerosing OID is one possibility. To evaluate the chest and abdomen findings to support any systemic findings in the chest or abdomen, CCT chest and abdomen was done, which however was normal.
PET CT scan was also done for this patient, for which there was non-metabolically active soft tissue thickening seen in the retrobulbar space, but there was no definitive scan evidence of any metabolically active lesion in the present study in any other site to suggest any inflammatory infective neoplastic etiology. So coming to the treatment, this is a serial imaging of the patient, which was shown that there was an increase in the size of the scleral mesh was noted from the 31st of August to 7th September. The mission and IOP was maintained. So after the infection was ruled out, on 8th September 2025, oral steroid stap Vismon was started at a dose of 1 milligram per kilogram, and the patient's response was observed daily. So further, patient gave said that he noticed that was symptomatically better. His pain has reduced, congestion reduced, but the area of sterile mesh showed an increase. Also, the ESR and CRP had reduced in values from the baseline values. And also, further, however, since an area of sterile mesh showed an increase, a single dose of IV prednisone 500 mg in 150 ml of normal saline was given. Further, biopsy was planned based on the imaging reports. Biopsy of the orbital mass was planned by a nasal endoscopic route on 17th of September. However, the patient was incorporated for the procedure and hence it was rescheduled. However, nasal custom obtained was sent for KOH and Gramstein, and it showed the sample showed aseptate hyphae, which is susceptible of mucus, and hence steroids were halted till further biopsy reports were available. Further, on 20th September, endoscopic biopsy was done and the sample sent for KOH and histopathological examination. Since the steroids were halted for a period, ESR and CRP showed a raise in their values, And further, the report from KOG histopath came negative for fungal elements. Again, from 29th September to 1st October, 2 more doses of IV nasal prednisolone was given. I welcome Dr. Ashish Sanghi from ENT department to carry out further discussion regarding the biopsy and their findings.
A very good afternoon to everyone. So, when the patient was subjected to the direct nasal endoscopy, what we found was on the right side, the cavity was a post-operative site with the large posterior central perforation in the bony and the cartilaginous septum. Along with that, the mucosa was slightly paler, and these were more suggestive of like a post-operative changes or a healing maxillary and the post-operative cavity. On the left side, we could appreciate the same perforation was present in the septum, and there was no bony exposed, only discharging bone was seen. There was no crusting was seen. So the endoscope, and after that, on confirming that nasal findings, we proceeded with the left side endoscopic biopsy where from the orbital part, that was the mass that was seen on the scans. By the medial approach, the biopsy was taken after removing that medial orbital wall, and what we found that there was some gritty, soft consistency PL2 whitish tissue was present, which we had sent for histopathology.
I invite Dr. Ashmita Shukla, senior resident from Department of Pathology, to discuss the histopathological findings and her insights.
So on histopathology, we saw that it is a low power image and we are seeing 3 fragments of tissue. Going to the high part, we can see there is a type of boiling type of fibrosis, or we can see even it is an onion skinning type of fibrosis. Further going to high part, we can see that this fibrosis is mostly around the small blood vessels. And there is a very scant inflammatory cells, which is mainly lymphocytes. We are not seeing any plasma cells or eosinophils, and we are not seeing any granuloma or giant cells, ruling out the infective condition. Also, we are not seeing any tumor cells. In meningioma, we can see such type of boiling architecture, but there is no tumor cells. So we are ruling out meningioma on this, and also there is no vasculitis, no inflammatory changes around the vessels. So there is no anti-associated vasculitis, which is one of the differential we can think of. Also, there is no cellular fibrosis and obliterative phlebitis, which are characteristic for IgG4 related diseases. So we are trying to rule out on the HP, and further we did special stain to rule out any fungal infections. So silvermethanamine and PARP were negative. Also BVG was done, and we can see that there is a rolling around the blood vessels and not inside the blood vessels. So it is a type of angiocentric pattern of fibrosis, that is a perivascular pattern. And immunohistochemistry we did too, that is SSTR2A and progesterone receptor, which is ruling out meningioma. And in IgG4, we are not getting any type of plasma cells, which are usually highlighted. IgG4 usually highlights the plasma cells in IgG4 type of related diseases. So, considering all this, we are thinking of eosinophilic angiocentric fibrosis, but since the patient is on steroid therapy, there is a positive of inflammatory cells and eosinophils. So the best diagnosis we can think of is eosinophilic angiocentric fibrosis in a late stage. Thank you.
Further, on 13th of September, the patient status the pain has been reduced and there is an improvement in vision noted. Vision has been improved to 4/60. As seen in the image, the congestion has decreased. IOP was well on the patient. Even the AC cells has reduced and vitreitis was still present, but the media haze has reduced to 2+. Again, on 4th October, a scleral biopsy was attempted from the supratemporal margin of the scleral thinning. But since the reports were inconclusive, another biopsy from the scleral site and orbital mass was done by the oculoplasty team on September 9th. This is the orbital biopsy video. Orbital biopsy video showing from the transconjunctival root inferiorly, careful dissection was done, orbital septum was made, and an orbital mass which was palpable was observed, and further, by careful dissection, an incisional biopsy of the mass was done. This was done by our Professor Rachna ma'am from the ophthalmology department of ophthalmology. As we can see, a small mass was noted and a careful incisional biopsy was done. Further, scleral biopsy was also done on the same sitting. Here, we choose a site temple to the scleral met, where the scleral nodule was observed in the CT images. Conjunctiva was nicked and careful dissection was done. And further, the lateral rectus muscle was poked, and an infiltrated mass was noted. Infiltrated mass like scleral nodule was noted, and again, a careful biopsy from that side was done. Here, you can see the LR muscle is poked, and a careful dissection of the scleral nodule is done. So histopathology of the biopsy was done, and the biopsy report of the scleral nodule showed inflammatory cells, including plasma cells, were present, but the immunohistochemistry is awaited. Further histopathology of the orbital lesion again showed similar pictures seen as the first biopsy, which was dense fibrosis and sclerosis, and there was no inflammatory cells. Further, based on this, the diagnosis of right eye sclerosis post-extubation and left eye immune-mediated necrotizing scleritis was made. And our main differential was here as IgG4 related disease, since the patient had raised blood IgG4 levels. Inflammatory myelofibrosis tumor because histopathy of the other eye showed IMT. It can be a rare recurrence or a metachronous disease. And a granulomatous polyangiitis, which is an anger negative, which is a classic cause of necrotizing scleritis, and it can be anger can be negative in some cases. And there is also a presence of septal perforation, which was noted in nasal endoscopy. So further, our management plan, following comprehensive evaluation by the rheumatology team based on clinical assessment and relevant investigation, the patient has been planned to initiate rituximab therapy, 1 gram intravenously, 2 doses, 15 days apart. So further to the discussion part, causes of scleritis can be broadly classified into non-infectious and infectious. Infectious can be exogenous and endogenous. Systemically, endogenous causes are mainly TB and syphilis. Exogenously, it can be because of trauma spread from keratitis, etc. However, in our case, it was a non-infectious cause. So it can be an autoimmune, and there is a wide variety of causes. It can be rheumatoid arthritis, SLE, GP, IgG4 related, etc. Or in some cases, drug-induced colitis have also been noted, especially in case of bisphosphonates, topiramate use, etc. And miscellaneous causes by such as foreign body granuloma, surgically induced necrotizing scleritis, as well as in some cases of malignancy, IMT, as well as last-grade scleritis have been reported. So in our case, these are our main DDs, that is IgG4 related disease, IMT, and anger-negative GPA. So our patient typically falls in the middle age group and had a male predominance, which is commonly associated with IgG4. But IMT is commonly seen in children or young adults with a slight female predominance. And anger-negative GPA is again seen in middle-aged adults, 45 to 60 years. Clinically, IgG4 is associated with a painless or mildly painful proptosis, lacrimal gland enlargement, chronic scleritis, etc. Whereas IMT might have a painful proptosis, and scleritis association is very uncommon in such cases. Anger-negative GPA is associated with painful necrotizing scleritis, and systemic involvements are commonly seen, such as upper respiratory tract features, kidney involvement, etc., which was not present in our patient, but nasal endoscopy showed septal perforation. Histopathologically, examination of PC-IgG4 is associated with dense lymphoplasmacytic infiltrate, storiform fibrosis, obliterative phlebitis are described. IMT has spindle-shaped fibroblastic and myofibroblastic proliferation with inflammatory cells. And GPA has necrotizing granulomatous inflammation and small cell vasculitis with giant cells. Initial investigation of PC serum IgG4 will be elevated in IgG4-related disease, which is seen in our patient. And histopath will have IgG4 positive plasma cells, which is not present in our case in the initial biopsy. IIT will show ALK positivity or smooth muscle actin positivity, and GPA will have C anger positivity. Coming to the treatment, steroid is common treatment for all these three cases, and the prognosis by IgG4 is associated with a very good steroid response, but relapses are common, and anger-negative GPA has an aggressive course. This is the diagnostic criteria for IgG4-related disease. We know in imaging there should be an enlargement of lacrimal gland, trigeminal nerve, extraocular muscle. Histopath examination should have marked lymphocyte and plasmacyte infiltration and fibrosis. And blood test should show elevated serum IgG4 levels. If all three are positive, it is a definitive diagnosis. It is probable when 1 and 2 are satisfied and possible when 1 and 3 are satisfied. So if we go to literature review, possible IgG4-related diseases are observed. The case of necrotizing scleritis is very similar to our clinical picture. This is a case report where a 51-year-old female had ocular pain, redness recurrent for the last 9 years, and the vision was 3/60. And there was diffuse swelling and congestion of temporal sclera with area of necrosis. Again, fundus showed vitritis, exudative RD. And on scleral biopsy, they found dense infiltrates of lymphocytes and plasma cells with perivascular arrangement. And hence, a diagnosis of IgG4 was made, and they were treated with steroids and immunomodulator, and the vision improved up to 6/12 by 3 months. Further, multiple case reports with in cases of IgG4 associated with recurrent scleritis has been noted in literature. But the main important point is IMT associated with scleritis, there's only one report, or very minimal report that is available. This is the case of a 14-year-old boy which presented with nodulus scleritis. And further, he underwent excisional biopsy, and histopathology showed an inflammatory myofibroblastic tumor. Similarly, associated with granulomatous with polyandritis, scleritis is very commonly seen, and it is found that scleritis can be a harbinger of GPA. That is, many cases present initially with scleritis and was diagnosed with GPA, that is vegetables. However, in this article, they found there is a morphological overlap between inflammatory myofibroblastic tumor and IgG4-related disease, and they found that if these cases involve virtually every organ, with both disease characterized by rich inflammatory infiltrates. And they found that there might be immunohistochemical overlap between these conditions. Initially, it was understood that on routine histological evaluation, IgG4 had a characteristic storiform fibrosis, obliterative phlebitis, and increase in IgG4 positive cells, whereas IMT lacked these features and instead they show a prominent population of spindle cells. However, there is an inadequacy in these cases because highly inflamed IMT, that is inflammatory myofibroblastic tumor, can be morphologically indistinguishable from IgG4-related disease. In such conditions, the distinction mainly relies on immunohistochemistry or for ALK and ROS1, and patients with percentage single organ IgG4-related disease should also be assessed for IMT. And the diagnostic algorithm should also include ALK and ROS1 immunohistochemistry, which is clearly explained in this article. So basically, a workup of a case of scleritis based on history and clinical features, as we see. We have to first rule out if it's infectious. Microbiological workup should be done. Biopsy can be sent for staining and culture. And start them on empirical antibiotic. If microbiology is positive, specific therapy can be started. If it's negative, and if improvement is present, we can continue the same empirical therapy. However, if there is worsening, repeat biopsy should be done and investigate for other causes. If we suspect an immune-mediated case of scleritis, then systemic workup and histology referral should be done. And imaging is done in specific cases. So, a backward blood investigation imaging is suggested. And we have to start the patient on oral steroids and immunomodulators as early as possible. So, this workup of this case was basically a multidisciplinary approach. The patient was present in ophthalmology. We needed the assessment of rheumatologists, pathologists, radiologists, ENT, and endocrinologists, and all of their contribution was significant for the diagnosis and management of this case. So coming to the summary, clinical overview, patient presented with necrotizing anterior scleritis in his bony seeing eye, history of acceleration of the contralateral eye for an orbital mass, histopath confirmed INT, current eye had progressive scleral thinning, pain, inflammation, decreased vision, and vitritis. Septal perforation is also noted on nasal endoscopy. Key investigation, serum IgG4 levels are elevated, can raise suspicion for IgG4 related disease. ESR and CRP are elevated. And is negative, but it does not rule out GPA, especially limited or anti-negative variant has been reported. Imaging shows no distal other organ involvements are not present. And biopsy of the lesion, orbital mass has an eosinophilic angiocentric fibrosis, very commonly seen in IgG4 related disease. And scleral site biopsy.
You overstep your time. We will make some time for discussion. Okay.
Yes.
We'll read this on our.
Time is less, so I was being not just involved in the case. So I'll give you some clinical persons, the audience is predominantly ophthalmology. I think I'll take this opportunity, very beautiful case for teaching. Two or three things that are very take home. Like presenting patients to us what we really see. So serum IgG4 elevated is not into IgG4 disease, and very clearly seen from the criteria as well. So we do not give that much importance while making differential diagnosis. So might be elevated IgG4. We keep that to the side, but we do not make it as a correspondent to make it as point number one. Second, GPA, when you talk about localized, this is localized GPA. So when you talk about localized GPA, they are very, very difficult to diagnose because 50% of them can be anti-negative. So if they are either positive or disease, they are either negative. Then the diagnosis rests on the. So now why this case is very, very important? This case has had a duration of 8 weeks. The patient has taken excluded amount of steroids from 2020 to 2025 on and off. You would get episodes of red eye, painful red eye. You could take 20 mg of steroids, the disease would get better. Some of these episodes also had proptosis, steroids, they would get better. But no steroid sparing therapy was given, no definitive diagnosis was made. So it kept the disease under check. This was happening on and off, feeding to poor people. So when you have such a disease, the histopathology needs to be interpreted in the background of what the patient has received. So now if you do biopsies from the nasal mucosa, you will not get what you are anticipating. So if the disease behavior was 8 years of a steroid response, we call it steroid response for steroid dependent. So whenever the patient takes steroids, the patient got better. Whenever the patient discontinued taper, the patient flares up. So we do not expect that eosinophilic angiocentric fibrosis, no matter what the histopathology says, because this is treatment modified, this is steroid modified, so a lot of the inflammation part would be missing. So we do not expect this behavior 8 years disease in inflammatory myofibroblast. We do not expect this in eosinophilic angiocentric fibrosis. What this is consistent with is only two. One is localized GPA antagonist, second is IgG4. Now when it comes to teasing out these two, because it's treatment modified, if our histopathology was characteristic, it would have helped us. Like in this case, we have made all attempts at histological confirmation. When we cannot get it, we treat with drugs which work in both. So that's why the decision to treat with rituximab was made for this patient. If this is IgG4, will work there. If this is localized GPA, will work there. But really seeing the patient longitudinally telephone time. So whoever saw the patient, so this patient did not come to RBC before 2025. So wherever the patient went in 2020, if they had started a steroid sparing agent, he would have been saved from a lot of steroid toxicity. He's blatantly pushing void right now, has a lot of steroid toxicity. He would have been saved from that. His eye outcomes would also have been better. His one eye has already been accentuated. Let's understand, he did not need an accentuation at that point in time. So we made a treatment responsive disease into a single eyed patient because of a lack of awareness at all our medical centers. So that this really needs very beautiful teaching case. So this GPA, IgG4, sarcoidosis, lymphomas, Erdheim Chester, all these specific disorders may present to you for the first time this way. Looking at extraocular involvement is important. Looking at serologies, if they are contributing, help. Histopathology cannot go away from histopathology at any point in time. Sometimes we have to need 2, 3 biopsies because in one we are not able to clinch it. Nasal biopsies leading GPA is very poor. If they are present, they help. If they are not there, they do not help. So keep taking deep. I think this was a wonderful opportunity. I must congratulate the team. These teaching cases really need to be brought to these forums so that wherever these cases go, they can be seen. Nasal septal perforation. If you look at the odds, nasal septal perforation. Yes, nasal septal perforation. The odds, if you link up nasal septal perforation with scleroalacia perforans with orbital involvement, your odds of GPA become higher. So, if, from a clinician's perspective, I would treat this patient as localized
How often do we see fibrosis in the case of GPA on histopathology?
And that's what I was just going to discuss. That when I first saw the biopsy, we did not have most of the clinical picture what we have. But what was essential was the angiocentric onion skinning what we saw. There was paucity of any inflammatory cells. But then later we discussed that patient has been on and off steroids. So when steroids are there, everything goes away. So, but the essential thing is the fibroblastic reaction, what is happening. It is more of scleritis, sclerotic than cellular. So, previous IMT diagnosis, I don't believe in that. It would not have behaved like Dr. Siddharth said, it would not have behaved like this at all. So, this was never an IMT. So, first thing which came to my mind was sclerotic GPA. So sclerotic GPA will also present with concentric onion skinning around the vessels. But when we discussed the case and there was a lot of gritty sensation and all that, and over time, in the beginning also it was reported like that. So then I thought maybe IgG4 related disease, that is what I'm calling eosinophilic angiocentric fibrosis, that can many a times fall in the spectrum of IgG4 itself. It might present as eosinophilic angiocentric fibrosis, but it's basically an IgG4. So I think I also kept these two differentials, but I am going more towards eosinophilic and IgG4 because later on the scleral nodule and nasal also did not show any evidence of vasculitis because the patient was symptomatic but still did not show any histological evidence of vasculitis. But we can repeat a nasal biopsy from a crusted lesion or nearby an area which is still active rather than an old sclerotic lesion, and then maybe we can review the case along with that. But IMT I would not keep in.
Right. We like to finish at 3:30. And everybody knows before they come to this, they have 30 minutes. So I think the plan regards, make sure we finish in about 25 minutes so that they. But this is an excellent case. And brought it. So there are times when nothing adds up. And, things are pointing in different directions. How to face the situation? We don't usually bring it because we like to have well worked out cases at FODCCS. So thanks for bringing this down. One thing that we have learned over dealing with these patients is that it's good not to have one box and try to push the case into that and keep options open. So I like your approach of thinking that it might still be one of several different things. And it might be something that you haven't yet thought of. You might find out. So I think follow up and continuing to tell yourself that you don't know the answer and that you're looking for it is what is likely. I agree with Doug completely. The orbital inflammatory diseases are not easy to handle and manage. And I would call it a very frustrating pursuit for diagnosis. Our case typically exemplifies all that. So 2018 was the first presentation of this patient, and we know that he had an exaggeration of the right eye. And he must have had years of disease before he eventually underwent a exaggeration. That means his disease, if I assume, it must have started around 2015 or even before, at least 10 years, 10 long years, he's had use and abuse of steroids, as he said. And the imaging also showed that he had bilateral avascular necrosis of both hips as a result, which we haven't spoken about. This is the result. diagnosis is not easy. We give the same definitions in different order. It comes in another order with pathologists. Physician also thinks some similar lines, more or less the same. Eventually, steroids, high degree immunosuppression, and in the end, I don't know, patient has had very, I would say, surgery which was probably, I don't know how was it correctly was it indicated, identification for a benign disease. Test also, I think, post elective surgeon test was done, and now the orthopedician would be next in line to do something like a toe decompression to relieving of his prevascular post and secondary degenerative change. But anyway, very, very challenging case, and I hope we can learn. And there are so many of these patients come to us bilateral disease already. We know it's a systemic inflammatory disease. We know it's not going to be an easy diagnosis. And I mean, we only have to refer, and eventually we can come out with an algorithm and an approach to correct these cases. It will go along with.
Thank you everybody for attending, and I like, as you said about the diagnosis, the patient was in a limbo, and it's just because we had a CCR and I insisted that we should do this case, so since a little bit things got accelerated, and I luckily with the contribution of everybody, we have learned a lot from this case, and I'd like to really acknowledge Sri Devi and Aisha, and the serial photographs were also very good. Like when graduation, I saw the patient after a lot, and so he's definitely getting better because the information was coming out. So thank you everybody for attending, and